A very good morning and thanks for this opportunity. So we'll be discussing perioperative durvalumab with neoadjuvant chemotherapy in operable bladder cancer, the NIAGARA trial. So neoadjuvant cisplatin-based chemotherapy with radical cystectomy improves overall survival to the tune of around 8%, and it has been the standard of care for a long duration. However, half of the patients recover within 3 years. In the setting of MIBC, immune checkpoint inhibitors as adjuvant therapy have demonstrated disease-free survival in phase 3 studies like Checkmate 274 and the Ambassador trial. Checkmate 274 also shows a trend towards OS benefit now. Perioperative immune checkpoint inhibitors could improve long-term clinical outcomes by priming anti-tumor immunity before surgery and eradicating micrometastatic disease after surgery. Perioperative durvalumab was shown to be safe and efficacious in phase 2 studies by the Swiss group. NIAGARA is the first global phase 3 study to evaluate a perioperative immune checkpoint inhibitor, durvalumab, combined with neoadjuvant chemotherapy in cisplatin-eligible patients in MIBC setting. The study included adult patients, cisplatin-eligible MIBC, CT2 to T4A, N0, N1, M0 with a classical urothelial carcinoma or urothelial carcinoma with divergent differentiation. The patient should have been eligible for radical cystectomy and should have had a creat clearance of equal to or more than 40 ml per minute. The standard comparator arm was 4 cycles of neoadjuvant chemotherapy with gemcitabine cisplatin, followed by radical cystectomy, followed by no adjuvant treatment. The experimental arm was 4 cycles of gemcitabine cisplatin with durvalumab, followed by radical cystectomy, followed by 8 cycles of adjuvant durvalumab. The study had dual primary endpoints, which included the event-free survival and the pathological complete response. The event-free survival also included patients who could not ultimately undergo radical cystectomy. The statistical analysis used a multiple testing procedure with an alpha-exhaustive recycling strategy, and the first PCR analysis was planned at 6 months after the last patient underwent radical cystectomy. In interim analysis, the estimated number of events across the 2 arms was 410 for EFS and 288 for OS. Looking at the patient disposition, we can see it is a multinational open-label trial which had randomized 1,063 patients and 533 assigned to the durvalumab arm and 530 to the comparator arm. Around 80% of patients could complete the neoadjuvant treatment, whereas 85% underwent radical cystectomy and another 70% completed adjuvant treatment. Looking at the baseline characteristics, the groups are well matched. We can see around 1/4 of the patients were Asian, renal clearance with a creat clearance of 40 to 60 ml, wherein around 19% of patients. Tumor stage above T2 was around 60%, and majority of the patient had high PD-L1 expression by the CPS score, and majority of the histology was a classical urothelial carcinoma. 5% of the patient in both the arms had N1 disease. Coming to the first primary outcome, the event-free survival, with a median follow-up of 42 months, we have a hazard ratio of 0.68, with a median EFS at 24 months being 68% in the durvalumab arm versus 60% in the comparator arm with a delta of 8%. Coming to the event-free survival, after excluding patients, after censoring out patients who did not undergo radical cystectomy, still the hazard ratio stands at 0.69, and the 24-month EFS at 73 versus 67%, again the results being reiterated. Event-free survival by subgroup analysis across all the subgroup favors the durvalumab arm, irrespective of the tumor stage, the baseline renal function, the PD-L1 expression, the histology, and the lymph nodal status. Coming to overall survival, there was 25% reduction in the risk of death, and at 24 months, the OS for the experimental arm stands at 82% compared to the comparator arm, which is 75% with a delta of 7%. Again, overall survival subgroup analysis, across all the subgroup, there is a favor towards the durvalumab arm. Coming to the pathological complete response, the initial analysis was done in 2022. The initial PCR rates in the durva arm was 33% versus 25% in the standard arm. The second reanalysis in 2024, including 49 omitted samples, gave a final PCR rate of 37 in the experimental arm versus 27 in the standard arm, giving a delta of 10%. This was the further updated analysis which was presented at ASCO GU 2025. The event-free survival by pathological staging, from this graph we can see that PCR rate does matter, But perioperative Durva with neoadjuvant chemo had improved the event-free survival even in both the group, the PCR as well as the non-PCR. Similarly, the overall survival was also improved by Durva and neoadjuvant chemo in both the group PCR as well as non-PCR. The metastasis-free survival also came up in the updated analysis. So the metastasis-free survival at 24 months stands at 75% versus 65%. Looking at the adverse event, the grade 3 for adverse events look similar between both the arms, and treatment-related grade 3 for adverse events were 41% in both the arms, and outcome of death treatment-related was less than 1% in each arms. Any grade immune-related adverse events were 21% in the Durvalumab arm. However, majority of the toxicities were of the initial and the milder grade. Coming to adverse events leading to discontinuation of neoadjuvant treatment, it was same across both the arms, 14% in Durva and 15% in the comparator arm. Adverse event leading to patient not undergoing radical cystectomy was 1% in both the arms, and the reason majorly being patient denying to undergo radical cystectomy at that point. The adverse event leading to delay in surgery was 2% in the Durvalumab arm and 1% in the comparator arm. And looking at the adverse events in the adjuvant setting, treatment-related grade 3 for adverse events were only 6% in the adjuvant Durvalumab arm. This is the tornado plot which shows adverse events, and it is mostly similar and majorly contributed by the chemo. The main adverse events being fatigue, neutropenia, and nausea, whereas the Durvalumab arm, the main adverse immune-related events were hypothyroiditis, which was around 10%, dermatitis and colitis in 1 to 2% of patients. To conclude, NIAGARA is the first phase 3 perioperative immunotherapy study in muscle-invasive bladder cancer and has demonstrated a statistically significant and clinically meaningful improvement in EFS and OS. The EFS hazard ratio standing at 0.68 and the OS hazard ratio standing at 0.75. The EFS and OS benefit with Durvalumab were consistent across subgroups. The PCR results and the significant OS benefit support the perioperative approach. Addition of perioperative Durva to neoadjuvant chemo was tolerable, manageable, with no new safety signals. Neoadjuvant Durvalumab did not delay surgery and did not impact the ability of patients to undergo or complete surgery. So the NIAGARA supports perioperative Durvalumab with neoadjuvant chemo as a potential new standard treatment for patients with cisplatin-eligible MIBC. In the new analysis, both metastasis-free survival and disease-specific survival were improved with Durvalumab. Pathological complete response rates were more likely among patients who received Durvalumab. There was a 10% difference, but benefit with Durvalumab was seen in patients who did and did not achieve a PathCR. So, where do we go from here? Probably we need biomarkers beyond PD-L1, something like ctDNA, which could help us in escalating or de-escalating the treatment. And the question still remains whether we can avoid surgery and consider for bladder preservation approaches in such a setting. And the further post-progression therapies will have impact on overall survival, and accessibility to those post-progression therapies does matter at this point. The quantum of benefit regarding the role of neoadjuvant versus adjuvant component needs to be validated in future studies, and probably the future studies could look at a shorter duration and lower dose therapies. Thank you.